Today I am going to present the case on central Pontine Myelinolysis. Our patient was 76-year female, transferred to our hospital with the complaints of persistent loose motions, vomiting, low-grade fever for more than a week. In another hospital, when she was admitted, she developed drowsiness, diagnosed as having sepsis, hypoxia, hypotension, for which she intubated and put on mechanical ventilator. She was recently diagnosed as having carcinoma rectum 2 months back, for which she received chemotherapy and radiotherapy. When she was admitted here, she was intubated but conscious, obeying commands with the GCS of 11/15. She was hemodynamically stable, not on any vasopressor support, but she was having proximal muscle weakness. Investigation on admission showed anemia, leukocytosis, thrombocytopenia. There was severe electrolyte imbalances like hypokalemia, hypomagnesemia, with low phosphorus, low calcium, and there was deranged liver function test. 2D echo done outside showed staged cardiomyopathy with ejection fraction of 25%. During the hospital stay, she developed pancytopenia, fever, and chronic diarrhea, which was lasted for more than 3 weeks. For the proximal muscle weakness, we did nerve conduction study, which showed primarily there was demyelinating sensory motor polyneuropathy with axonal loss affecting both the upper limbs and lower limbs, for which she received IV IgG. We tried to wean her from the ventilator, but there was weaning difficulty due to proximal muscle weakness and respiratory muscle weakness. During the hospital stay, on day 18 of the admission, patient became drowsy. She was not obeying commands. EEG showed moderate degree of diffuse encephalopathy. We did MRI brain, which showed typical signal abnormality in the central pons, showing restricted diffusion, which was highly suggestive of central Pontine myelinolysis. This MRI picture showed a typical trident sign or a Trishul sign in the central pons. So what is the central Pontine myelinolysis? It refers to the acute demyelination seen in the setting of osmotic changes, typically with the rapid correction of hyponatremia. Osmotic demyelination syndrome, that is ODS, is the more recent term replacing the CPM, recognizing that not only central pons but other extrapontine structures can also be affected, which was known as extrapontine myelinolysis. So what are the risk factors to this syndrome? It is most commonly precipitated by the rapid correction of chronic severe hyponatremia. In that, when the serum sodium was less than or equal to 105, that is very severe hyponatremia. If the patient has history of alcoholism along with hypokalemia, liver disease with or without liver cirrhosis, in the post-liver transplant patients with severe malnutrition, and also in the patient of diabetes insipidus. So why there is only in the chronic hyponatremia? Because the brain adaptation takes at least 2 to 3 days. If it is less than 24 hours, there is a less chance of osmotic demyelination syndrome. But over 48 hours, brain adapted to the low sodium levels, and after that, when we rapidly correct the sodium, astrocytes and oligodendrocytes play the role in the osmotic demyelination syndrome, in which when we rapidly correct the sodium in chronic hyponatremia, astrocytes are not able to maintain the osmolality difference and intracellular shift with the loss of osmolytes like myoinositol, other glutamine, taurine, which causes the DNA fragmentation, protein aggregation, and cause the astrocytes and oligodendrocytes apoptosis process, because oligodendrocytes are important for the myelination when there is a demyelinating injury or primary myelination process. So how patient presents? Usually patient present after 2 to 6 days of overly rapid correction of sodium. Symptoms are irreversible like dysphagia, dysarthria, paraparesis with movement disorders. Patient can present with seizures, lethargy, confusion. In a severe state, patient go in the locked-in state in which patient is unable to move or unable to verbally communicate, but only eye movements are present and blinking is present. So how we treat the osmotic demyelination syndrome? The observational studies or randomized control trials showed there is no specific treatment for this disorder. Some case reports showed the role of steroids, plasmapheresis, and intravenous immunoglobulins, but no randomized trials to prove the role of above agents. So major burden is on the prevention. We have to prevent it because duration of hyponatremia is the major determinant. We have to know the duration. But when patient comes to you with the hyponatremia, we don't know since when the patient's sodium was low. So whenever a patient comes to you, it is safest to assume that the patient has chronic hyponatremia unless history suggests there is a water intoxication like marathon. So to prevent it, we have some guidelines and we have to follow that guidelines to avoid the overly rapid correction of sodium. There are two guidelines. There are American Expert Panel recommendation in which they say patients at average risk of ODS, there is a limit of 10 to 12 milliequivalent per liter in any 24 hour for the sodium correction. And patients at high risk of ODS, there is a limit of 8 in any 24-hour period. Other guidelines like European Clinical Practice Guidelines suggest daily limit of sodium correction should be 10 in the first 24 hours and 8 in every 24 hours thereafter. But some studies and trials show there is no extra added advantage of correcting the sodium more than 4 to 6 milliequivalent per liter in any 24 hours. So in clinical practice, we usually restrict it to less than 8, that is 6 to 8 milliequivalent per liter per day. So back to our case. In our patient, during hospital stay, there was never overly rapid correction of sodium. The maximum change in serum sodium in any 24 hour in our patient was 7 milliequivalent per liter. But patient was having prolonged persistent hypokalemia, hypocalcemia, other electrolyte abnormalities like hypomagnesemia, hypophosphatemia, and she was severely malnourished because she was a known case of carcinoma rectum with chronic diarrhea, not tolerating feeds. For these electrolyte abnormalities, we did IV and enteral corrections. So, in spite of all this, we unfortunately we lost the patient because of infections, ICU acquired nosocomial infections. She was chronically debilitated with the CA rectum and other infections with malnutrition. So I want to conclude this case as central pontine myelinolysis was, in our case, was not because of overly rapid correction of sodium, as I already said, but in our case, it most likely to be multifactorial. Other factors contributed are low potassium, low phosphate, low magnesium, and severe malnutrition. So take-home message from this case is osmotic demyelination syndrome is acute non-inflammatory demyelinating disorder. It occurs most commonly because of overly rapid correction of chronic hyponatremia. MRI brain is a diagnostic for this syndrome. There is no proven treatment as per studies, so we have to prevent it by strictly following the guidelines. And from our case, I could say that other metabolic causes should be kept in mind as positive of contributory factors to this uncommon disorder. Thank you.